My name is Ciara Kelly, as Diana already explained, a sarcoma medical oncologist from MSK. So I'm going to share my screen and hopefully, can everybody see my slides okay?
Yes.
Okay. So just my talk today, I really just wanted to give everybody a general overview of GIST and then focus on the medical side of things. And then Amy Craigo will focus on the local control options and in particular surgery. So just as by way of background, GIST is, as we know, a very rare sarcoma. We see maybe about 5,000 cases in the US every year. It is one of the most common sarcomas of the GI tract, and its incidence has been rising, and that's probably due to more accurate diagnosis and so in terms of age at presentation, the median age of presentation is 65. However, we do see these tumors occasionally in pediatric patients where the median age of presentation is around 15. We see an equal distribution in terms of gender, although with STH deficient GIST, a subtype of GIST, we see this more commonly occur in women. In terms of the primary site of the disease, we most commonly see these occur in the stomach, and then less commonly in the small bowel, and then very rarely, or less common again, in the rectum or large bowel. Sorry. So in terms of the pathogenesis, or what causes GIST, or where does it arise from, it's truly uncertain, but it's hypothesized that GIST arise from the pacemaker, what's deemed to be called the pacemaker cells of the GI tract, the interstitial cells of Cajal, and these lie within the intramuscular layer of the bowel wall, and their function is to regulate peristalsis, which is essentially the movement of food through the GI tract. With respect to presentation, the most common presentation is that patients are symptomatic with this, presenting with anemia, often bleeding from the tumor, be that in an occult manner where it's detected on routine lab work perhaps, and showing a low a hemoglobin count, and indeed together with that iron deficiency, or it can be frank bleeding where we're seeing dark colored stools. Less commonly, we see patients present with acute abdominal pain, which may reflect a perforation of the tumor rupture. And then in 15%, we see abdominal pain being the presenting feature. In cases where we see the GIST arise within the rectum or large bowel, we may see bowel obstruction and constipation being more common presentations. We also find that in about 25% of cases, it's an incidental finding where it's picked up on imaging or endoscopy that is performed for another reason. In terms of diagnosis, so we focus on imaging and also diagnostic procedures and ultimately biopsy to help us diagnose these tumors. So imaging can include a CT or an MRI. MRI can be particularly helpful for looking at the liver. We're essentially trying to determine the extent of the tumor within the body. We don't often see tumors spread to the lungs, but we do recommend a CT chest for tumors that are over 2 centimeters. And then PET-CT, you may have heard of. This has a special role in terms of when we're considering using medical treatments such as Imatinib before a surgery, and we're looking to use a PET to see if we can determine if there's early response to treatment. And also in the advanced setting, when we're seeing maybe features on a CT or MRI that are ambiguous, and we want to characterize these further and determine if there's viable disease or subtle growth occurring, that's when we will also consider using a PET-CT. In terms of diagnosis, this is often by EUS and biopsy or an IR-guided biopsy. And so when a biopsy is performed or a surgery is performed, our pathologists look at the material for us and help to characterize this further. In terms of the tumor size, these can range from millimeters to over 10 centimeters. As I explained earlier, they generally arise within the intramuscular layer of the bowel wall. Features that can be evident include ulceration and hemorrhage, bleeding. In terms of most often we see it as presenting as a solitary tumor, but we can also occasionally see satellite lesions in the adjacent peritoneum, which is essentially the lining of the abdominal cavity and encompassing the organs. And less often we see it being multifocal, and this is something that we can see in SDH deficient GIST, where we see multifocal lesions within the stomach. And so when a pathologist looks under the microscope, they will refer to how these cells appear. And these can be spindle cell in the majority, 70% of GIST, epithelioid in 20%, and then a mixed pattern in about 10%. And then a pathologist will also use certain markers that they use to stain the material that maybe show, and their positivity or negativity then can help to confirm the diagnosis. So commonly we will see c-KIT being positive, DOG1, and CD34. So the GIST can be now molecularly classified, and this is essentially looking at the genomic features of the tumor. And so the majority of GIST harbor mutations in the gene called KIT. Within that, we see most commonly KIT exon 11 mutant GIST. Then next would be KIT exon 9 in about 10% of GIST. And then apart from KIT, the KIT gene, we see mutations or alterations in PDGFR alpha in about 5 to 8% of cases. And then we have what we call KIT or PDGFR alpha wild type tumors. And this can be broken down into those that have BRAF positivity or SDH deficiency, NF1 related. And then there are those that are very occasionally, we can see translocation associated GIST. And then those that are truly wild type, and we haven't, let's say, delineated the exact underlying molecular characteristic of those tumors. In terms of staging at presentation, a stage of a tumor essentially reflects where exactly in the body that we see the tumor. And so the majority of GIST when they present are localized in about 80 to 90% of cases. And then 10 to 20% will present with more advanced disease. And where we see disease most commonly will be in what we call the liver or the peritoneum or omentum. Lymph node involvement is not very common in GIST, although we do sometimes see it with SDH deficient GIST. And then lung metastasis spread to our lungs is rare, unlike other sarcomas, actually, where lung involvement can be more common. This is something that we see often in more later stages of the disease. In terms of management, when we have localized disease, often the priority of treatment is surgery, particularly for tumors over 2 centimeters or greater. For those that are less than 2 centimeters, there is no real true consensus yet regarding their management. However, for patients who have high risk features on endoscopy, surgery is considered. And for those with no evidence of high risk features, then periodic endoscopy or imaging surveillance can be considered. And those then for and I think Dr. Krieger will probably go into this in a little bit more detail. For patients who have operable tumors, however, they're large and we're concerned about the potential more complications of that, we can consider utilizing Imatinib for Imatinib sensitive GIST before surgery. And the duration of therapy in that setting, we generally advise that Imatinib is considered is used until maximal response, which is often around 6 months that we tend to see that. And now with Avapritinib approved for PDGFR alpha exon 18 mutations, and this is also an option for patients with GIST harboring those mutations. In terms of risk stratification and prognosis, so essentially once a patient has undergone surgery for a localized disease, we then need to determine whether or not it is helpful for a patient to be considered for treatment with imatinib after surgery. And the features that we look at include the primary tumor site, the size of the tumor, larger, being over 5 centimeters, are associated with higher risk, mitotic rate, high being over 5, low being less than 5 per 50 high power field, high being associated with a higher risk of recurrence. Tumor rupture is also associated with a higher risk for recurrence. And then we also look at molecular features. So we utilize all of these characteristics of the tumor to determine whether a patient is at risk, high, let's say intermediate or high risk for recurrence, and then whether or not adjuvant therapy should be considered. And I've just listed out the classification or the classification schemas or nomograms that we will use to help us predict for risk of recurrence. And the fact that there are so many highlight that, you know, it's not clear cut, and there are slight nuances to each nomogram. And I generally, when I see a patient, I'll look at all of these nomograms and then use the collective knowledge and information I receive from all of those to make help guide patients. So with respect to adjuvant therapy, imatinib is the adjuvant therapy that we consider using for imatinib sensitive tumors. So those that are KIT mutant or PDGFR alpha that is non-DA42V. And avapritinib can be particularly useful for patients in the neoadjuvant setting or advanced setting, but in the adjuvant setting, avapritinib has not been looked at yet. So with imatinib, we essentially have evidence from a number of clinical trials and supporting its use in the adjuvant setting. Their first trial looked at 1 year of imatinib after surgery versus none, and 1 year was shown to improve patients' outcomes and reducing the risk of recurrence. Then we had another study looking at 2 years versus none, and again, 2 years with imatinib was shown to be beneficial. And then we looked at 3 years versus 1 year of imatinib after surgery. And again, 3 years of imatinib was shown to be beneficial in terms of helping to reduce the risk of recurrence and helping people live longer. Each of these trials used slightly different criteria to allow patients enroll. Essentially, we will consider adjuvant therapy for patients who are deemed to be high risk or intermediate risk also. And within the intermediate risk, there can be nuances there that we look at in terms of trying to guide a patient. But the optimal duration of adjuvant therapy is currently unknown. There was a phase 2 study looking at administering 5 years of imatinib therapy after surgery. And again, we saw really good outcomes with respect to reducing the risk of recurrence in this group. And there is currently a trial ongoing looking at 5 years versus 3. So we hopefully will learn more from that. But I think those of us that treat this tumor feel that if the risk warrants consideration of imatinib and a patient is tolerating treatment, we often will continue with imatinib therapy even beyond the 3-year mark. But that warrants consultation with your oncologist to discuss that and weigh up the pros and cons of that. And I briefly had spoken about neoadjuvant therapy earlier, and this is essentially where we utilize imatinib before a surgery, helping to reduce the size of the tumor and help to facilitate a surgery. And Dr. Krieger may speak on this shortly. With respect to advanced GIST, there are a number of medical therapies that we can consider, and I feel that medical therapies represent the cornerstone of treatment for patients with advanced disease. Having said that, we also will consider utilizing local options for local controls such as surgery or ablation procedures or embolization, and ablation and embolization in particular can be helpful for liver involvement. So imatinib represents the first FDA-approved drug and is approved for the first-line use of in the first-line setting for GIST. And this was approved in 2002. And we saw with this study that about 80% of people will benefit from this therapy. We'll see tumor shrinkage in about 50% of cases, and a further 30% of cases will have stabilization of disease. So this represents the timeline for FDA approvals of medications in GIST. So as I explained earlier, Imatinib was first approved in 2002. And then since then, we've had Sunitinib approved in the second line setting in 2006, Regorafenib in the third line setting in 2012. And then in 2020, we've had Ripretinib and Avapritinib approved, which is fantastic, showing us that the research that is ongoing is thankfully leading to drug approvals and more options for our patients. So this, I'm not going to go into in a lot of detail, but I wanted to have it there for patients to be able to reference back to, as I know this meeting is going to be recorded. So I thought it might be helpful to have that here. But essentially, this highlights all the studies, majority of the studies that have been conducted using the FDA-approved agents and the benefits that we've seen. Essentially, though, why do we need more treatment beyond Imatinib? Imatinib works very well, thankfully, in the first line setting, but unfortunately, we will see around 2 to 3 years on treatment is around the average point where patients may start to progress. And we see this, why exactly a lot of the mechanisms we're still learning about, but we do know that about 70 to 80% of patients with KIT mutant GIST will have evidence of secondary KIT mutations that lead to a resistance to Imatinib. So this is more information again about Sunitinib in the second line and Regorafenib in the third line. Once we move beyond Imatinib, the ability of our drugs to achieve tumor shrinkage is less. So we see response rates in the order of about 17% with Sunitinib, around 4.5% with Regorafenib. But what we do see is that they can delay the growth of the tumor, and that's where a huge benefit occurs for our patients, thankfully. In terms of, you will often hear about, knowing about the genetic makeup of the tumor and how important this is. It's definitely important in earlier stage disease where we're considering adjuvant therapy, where we will only consider Imatinib for Imatinib sensitive disease such as KIT mutant or PDGFR alpha non-DA42V. And similarly, in the advanced setting, it can be very important also to know the genetic makeup of the tumor. And the reason for this is we have seen studies whereby there are greater benefit for one drug over another has been seen based on the genetic profile of the tumor. So here it was a study showing that Sunitinib seemed patients with KIT exon secondary mutations in exon 13 and 14 seemed to do better with Sunitinib than those with KIT secondary mutations in exon 17 or 18. This is the data reflecting the Ripretinib phase 3 study that was recently resulted and showed an improvement in progression-free survival for Ripretinib over placebo. Progression-free survival essentially means that it's delaying the growth of these tumors, and we see a considerable improvement over placebo, right, a 5-month improvement. And again, response rates are on the lower side in terms of tumor shrinkage, 9% versus 0% in the placebo. And then this reflects the Avapritinib data for PDGFR alpha D842V mutant GIST. And we can see with the waterfall plot on the right-hand side of the screen, you can see that each column reflects a patient and they're going downwards. They're going in the right direction, so which reflects tumor shrinkage. So, the majority of patients receiving this medicine in this subtype of GIST benefit from this treatment. And this is remarkable data to show, given that prior to Avapritinib, we really didn't have any great medical therapy for patients with this type of GIST. So as when I meet my patients, though, I will always consider clinical trial options at every aspect of the treatment course, be that in the adjuvant setting, if there was a trial to consider, or in neoadjuvant, or in treating advanced disease. So there are a number of clinical trials ongoing, and that may be reasonable to consider. And, it's always good to ask your oncologist about clinical trials and are there any ongoing that they can look into for you and consider you for. Beyond clinical trials, once we've moved beyond, let's say, all the standard approved drugs, there have been a lot of other medicines that have been looked at in GIST. And I included this slide so as a reference point. And some of these are may be available for patients, as they are not FDA approved, but they are NCCN compendium listed, and therefore they may be available for patients, and these can be potentially considered following progression on the standard options, or indeed if there's no clinical trial option available. So I'll wrap it up there, and I'm happy to answer any questions, and be that now or later.
Yes, if we could hold the questions until after Dr. Crago presents.
Okay, great. So I'm gonna just share my screen here. Okay, well, thank you very much for having me today. I'm gonna spend a little time just talking and using Dr. Kelly's talk as a springboard to kind of look at how surgery fits into the management of GIST, and how we combine surgery with some of the medical therapies she discussed in detail to treat patients long-term with the disease. So the common indications for surgery in GIST patients are primarily treatment for localized primary disease. So in some patients, we use surgery alone to be curative. Sometimes we use surgery after an initial course of neoadjuvant imatinib. And in other patients, we use surgery and then adjuvant imatinib to keep the disease under control for long periods of time. Surgery can also be useful in a subset of patients who have recurrent or metastatic disease, but in those patients, it's really as an adjunct to imatinib or another tyrosine kinase, which becomes really the primary treatment modality. So we use surgery to improve the outcomes of imatinib or the tyrosine kinase inhibitors, either because there may be a site of resistant disease that needs to be removed so that the drug continues to work, or there may be a site of symptomatic disease and we need to do an operation to try and improve a patient's symptoms. So I've really kind of structured this talk around some common questions that patients ask me when they come to talk about surgery for their GIST tumors. Of course, one of the first questions many people will ask is, how am I going to do after surgery? So surgery is curative for many patients with GIST, and this is data based on 1,000 patients who underwent surgery for these tumors at our institution between 1982 and 2016. So you can see on this Kaplan-Meier curve, it plots how many patients remained alive over time. And this is stratified based on whether the patients had complete resection, complete gross resection, meaning we got out all the tumor that we can see, versus whether or not the tumors were only partially resected. And so in patients who have their tumors completely resected, you can see that at 5 years after surgery, over 80% of patients are still alive. So surgery really can be a great backbone for treatment of patients when you think that you can remove all of the tumor. That number is even better if you look at the patients who were treated after the institution of imatinib as an adjuvant therapy for patients with high-risk GIST. In that case, about 85% of patients remain alive after surgical resection. We know that the tumors are more likely to come back if the tumors are larger, if they happen in the small intestine or the colon as compared to the tumors in the stomach, and if under the microscope they have a higher mitotic count. So if the pathologist can see that the tumors are growing rapidly, then those tumors are more likely to come back after surgery. And we counsel our patients based on several different risk stratification schemes that incorporate all of these 3 characteristics into one sort of prognostic model. So 2 of the common ones are the Matinin Criteria, and this will categorize a tumor as very low risk of recurrence if it's small and it has very few mitoses, so isn't dividing very quickly at all. Low malignant potential if the tumors are in the stomach and between 2 and 10 centimeters and have a low mitotic index, or if they're small with a higher mitotic index. In the intestine, the tumors are low malignant potential if they're small or less than 5 centimeters, five mitoses per 5 viral field. And intermediate and high malignant potential tumors are characterized that based in those categories if they start to have more than one of the risk factors for recurrence. So a tumor with high mitotic count in the intestine compared to the stomach, or tumors that continue to be, are tumors that have grown larger than 10 centimeters. So each of those iterative risk factors starts to put you in a higher risk, at a higher risk of recurrence. The Gdol Nomogram takes each of those characteristics. It doesn't dichotomize them quite as much, but on a more continuous scale, assigns points for different characteristics. And then you add up the points that you get for size, mitotic index, and site, and then that helps you to determine a risk. So for example, if you have a 40-year-old who comes to you with an 8 centimeter gastric cyst that has 3 mitoses per high-powered field. So this is the mitotic index, how the pathologists tell us how quickly the tumor is dividing. Then you can see based on the Matinin criteria, this is a gastric tumor between 2 and 10 centimeters, and it has less than 5 mitoses per 50 high-powered fields. So this is a low malignant potential tumor. And based on the Matinin criteria, low-risk tumors are those with less than 10% recurrence. If you plug this into the Gdol Nomogram, what you see is an 8 centimeter tumor gets 45 points. The fact that it has a low mitotic index gives you no points. The fact that it's in the stomach, again, no points. So this patient has a total of 45 points in the nomogram. The total of 45 points puts you at a risk of just about 15% recurrence after 5 years. So this is a little higher risk in this predictive model than in the Matinin criteria, but in the same overall range. If you look at a patient who then, instead of a gastric tumor, has an intestinal tumor with still a low mitotic risk and an 8 centimeters, so the same size, this change from gastric to intestinal puts you in a higher risk category, so an intermediate malignant potential. So intestinal tumor 5 to 10 centimeters, less than 5 mitotic index, and intermediate risk tumors by the Matinin criteria have a risk of recurrence between 16 and 24%. Here, if you look at this at the Gdol nomogram, this is a low mitotic index. It's a small intestine tumor, so you're getting about 40 points. Again, 45 points for size. And so you can see, instead of having a risk of just about 15% like the stomach tumor had, this tumor has a risk of about 15% recurrence after 2 years, and more like 30 to 40% after 5 years. So again, the nomogram estimates the risk a little bit higher than the Matinin criteria, but in that same sort of intermediate category. And a 40-year-old gastric cyst, 8 centimeters, now you're seeing this high mitotic count. This patient is in a high malignant potential category with a risk in the Matinin criteria over 30%, about 35% or over, and in the Gdol criteria, a 2-year risk of recurrence in the 60% range. So,
Dr. Craigo, can you raise your voice a little bit?
yes, of course. Sorry. So you can see how these different risk predictor scores help us to sort of estimate what a patient's risk of recurrence is, and that lets us tell them how surgery is going to contribute to the ability to cure the disease, and it also helps us to determine who may benefit from getting imatinib after surgery, and that patients who have intermediate risk or high risk tumors often are referred to medical oncology to get imatinib after as an adjunct to surgery to try and improve the outcomes. Okay, so another question we often get asked, what's my recovery going to be like? This is just a schematic of where we see the tumors occur. Dr. Kelly showed something quite similar. So most of the tumors we see in the stomach, others in the small intestine. Rarely we may see tumors in the colon and rectum, in the esophagus, and the duodenum. So our surgeries are really geared toward removing the tumor with about 1 centimeter of normal margin all around it. We try our best to avoid rupturing the tumor so that no cells are spread. And we take any of the adjacent organs that are adherent to the tumor. So this last factor, what tumors need to be removed, what organs need to be removed in order to get the tumor out, really helps us determine what recovery is going to be like. So if you have a small tumor in the stomach, I can take this out with a lot of normal margin all around it and just make a small repair in the stomach. And in that context, what we call a gastric wedge resection, patients are usually just in the hospital between 2 and 5 days. If we have to take a larger part of the stomach, say for example, the whole lower half of the stomach, or if we have to take a piece of intestine, those types of procedures often mean that the intestines don't work as well over the first few days after surgery, and so patients can't eat well. And in that context, you may need to stay in the hospital for more on an average of 4 to 7 days. And then if we start to have to take out multiple organs in order to remove the tumor in one piece, then those patients may even need to stay in the hospital up to 2 weeks, not only because the intestines may not wake up as quickly, but because there's an increased risk of having complications after surgery, for example, abscesses that may form and need drains placed. So that's the what the initial recovery can be like. It's very dependent on where the tumor is and what kind of operation we need to do. Most patients who have an open procedure, it takes about 3 months to get back to their overall baseline level of activity, often because big surgeries make patients very tired after and for a prolonged period of time. So about 4 to 6 weeks till they're moving normally enough to drive, 6 weeks until you can really lift anything. Most people take about 2 months off of work, and then about 12 weeks after surgery, like we talked about, to really get all of your energy level back. We've tried to improve this in that in some patients, you can undergo surgery via laparoscopy. So this means you just have small incisions where we place cameras in the abdomen to take a look around and to remove the tumor. The important thing when we're picking patients who may benefit from laparoscopy is we have to be confident that we can take that tumor out again without rupturing it. So many of the tumors that are resected laparoscopically are really the stomach tumors that are less than 5 centimeters in size. The benefit of laparoscopy when you compare it to open surgery, and this is a study that Dr. Strong and our at MSK did, where she compared 40 patients who had laparoscopic surgery to open surgery, is that there can be less blood loss, but also that patients have a shorter hospital stay. So most of the median time that laparoscopic patients were in the hospital for was 4 days versus 7 days for patients who had to have open surgery. So in selected patients, laparoscopy can really help to improve your recovery to some extent. Another thing we often talk about when patients come for consultation is who should have upfront imatinib. You can imagine that if we can give imatinib before surgery, it can reduce the tumor size, and that may make the surgery more straightforward. You may not need as many organs resected, or you may be able to have a smaller section of the stomach resected. So if we think that we can reduce the complications from surgery, improve your recovery, then we're going to try and give you upfront imatinib. And so this, again, is an analysis of the patients at our institution who got imatinib up front versus those who went straight to surgery. And you can see one of the things that determines who got the neoadjuvant imatinib is where the tumors were. So tumors in the stomach, we can often resect without giving imatinib up front. But tumors in the rectum, the rectum is low in the pelvis between the bones of the pelvis, and it's often difficult to take that out to take a large tumor out well, because you can't see as well in that area. So we'll often use imatinib to reduce the size of the tumor before we take it out if the tumor's in the rectum. Also, because those tumors can be close to the anal sphincter. And so we don't want to take out the sphincter if we don't have to, because that can affect continence. And so we'll try and give neoadjuvant imatinib in areas in tumors that are in regions like the rectum, because that can help us to preserve organs and function like that. So not only to improve your, to reduce your risk of complications, but also to improve the long-term complications of the surgery. You may choose to give imatinib up front. So site can affect who gets imatinib. Size, you can imagine the larger the tumor, the bigger the surgery. So often for patients who have tumors over 10 centimeters, we'll try and give the drug up front to shrink the tumor and do a better operation. And also, if patients have a tumor that we don't think we can resect up front, often we'll give imatinib to try and convert it to a resectable tumor. So here, patients you can see who had R2 resections, which is what we call a tumor, a resection where we leave tumor behind. Those patients often get imatinib up front. As Dr. Kelly said, the imatinib, when we give it in a neoadjuvant setting, we often give for about 6 months before an operation. This is just an example of a patient you can see that I saw earlier this year who presented with a large tumor, almost 20 centimeters in diameter. We gave imatinib, and after 3 months, you can see that it's shrunk by about half the size. And then if you look about 6 months later, it's shrinking a little bit more, but it hasn't changed significantly. So this is that 6-month time period where we're starting to see maximum response. And this is when we really operate on most patients who have neoadjuvant imatinib, particularly because we want to do it before the tumor develops any resistance to the drug, which we know can start happening after 1 to 2 years. So we follow patients who are getting neoadjuvant imatinib with serial imaging, like in this case. We're almost always gonna sequence the tumor to look at what the mutation in the tumor is up front to make sure that it's a tumor that's gonna respond to imatinib. And as Dr. Kelly mentioned, we may also consider doing a PET scan before and after treatment so that we can assess whether or not a tumor is sensitive to imatinib. We can see changes on PET after 2 weeks. And this is data from the original studies of imatinib in just patients. And you can see how this patient had active disease that was bright on a PET scan at baseline. And then even just a month after treatment, you can see that bright FDG avid tumor is no longer visible, because even though there's residual tumor there, it just isn't as active as PET. So we can tell that the tumor is responding by PET, and that gives us a very early sense of whether or not the drug is working. It's whether or not the PET response is visible. So most patients, if they're going to get the adjuvant imatinib, get that for about 6 months, and then we go on to surgery. The other context where we often see patients to discuss whether or not surgery is a reasonable option is either if their tumors have recurred, or if they had metastatic GIST that's responded, and maybe that's responded to a TKI like imatinib, and maybe now they're developing some resistant disease. So should these patients with recurrent disease or metastatic disease, for example, sarcomatosis or liver metastases, undergo surgery? And historically, the answer was, before we had imatinib, was no. So this was a study of 60 patients with recurrent, at the time, what it was called was gastrointestinal sarcoma. And you can see that outcomes were, when we used surgery alone to try and control disease, were relatively poor. So these patients had resection of metastatic GIST, and you can see even at 20 months, so less than 2 years, over half of patients had died from their disease. This is very different than what we see now, where even without surgery, patients with metastatic disease can live with years because of imatinib. the second and third line drugs that Dr. Kelly described. So who do we do surgery for with Imatinib? Well, those outcomes have gotten much better since we're doing surgery on patients who also have TKIs as far as treatment. And you can see here, this is a description of patients who were treated with surgery for primary disease and metastatic disease before Imatinib, and you can see how much worse they do than patients who undergo surgery now as an adjunct and in combination with treatment with Imatinib. So whereas at 2 years after surgical resection before Imatinib, again, over 50% of patients had died from their disease. Now, when we choose to do surgery for patients with metastatic disease who are being treated with Imatinib, we can control the disease, and patients are still alive in 80% of cases after 2 years. This is an example of a patient like this. So you can see they had presented with metastatic disease in 2013 that was not resectable. This was controlled on Imatinib for some time, and then they developed a solitary site of disease, which we took out last year. This is on PET scan. You can see it turned bright after about 7 years on Imatinib. We took this out, and that patient has no evidence of disease again after we resected the residual site of disease that was resistant to metastasis, to the treatment with the TKI. So this a patient like this, where we have control of the disease with the TKI, and there's only one site where we need to really resect the disease in order to control what part of the cancer isn't being managed with the drugs is really the ideal, one of the ideal situations where we use surgery for patients who have metastatic or recurrent disease. And this is a recent study that looked at which patients do best for surgery for recurrence and metastatic disease when surgery is used in conjunction with Imatinib. And you can see that this is how long after the operation patients live based on whether all of their disease is controlled by the Imatinib. So this is, these are these two lines at the top of this graph, whether all of their disease except one site is being controlled by the Imatinib, or whether you're trying to use surgery to control disease that's progressing at multiple sites. And if we really look at these patients who have disease that's only progressing in one site, or that's progressing or where the disease is stable, those are patients who do really well when we use surgery to augment the effect and the utility of the drugs. So overall, in terms of surgery for GIST, we know it can be curative for many patients. The side effects and the recovery from surgery depend on the extent of surgery required, including which organs are removed. We think that recovery may be easier after laparoscopic surgery versus open procedures, but laparoscopy, again, is only employed in certain cases where we feel confident we can get the tumor out without rupturing it. And we now know that since the institution of, since we started to use Imatinib and the other drugs like sunitinib and regorafenib, surgery can be useful in a subset of patients with recurrent and metastatic disease in order to help optimize outcomes. So thank you again for including me today, and I'm happy to answer any questions, as I'm sure Dr. Kelly is.
Thank you so much, Dr. Crago. And I'm just going to pause our recording.
I was just trying to share the screen and unmute. Thank you so much for having me, Diana. It's an honor to present today and to share a little bit about the registry and what we do as an organization to contribute to GIST. So can everyone see the screen? Perfect. Okay. So about the registry, we are the largest patient-reported GIST registry in the world. We have over 15 years of data enclosing 35 years of patient history, because as we may know that in 1999, GIST just started to having their own diagnosis, but we did have a lot of patients in our registry that did not have a GIST diagnosis. They had a misdiagnosis. Therefore, we have that information in Registry. And just to do a summary of what we collect in Registry, we collect information about demographics, we have diagnosis detail, any approved or off-label treatments. We're able to gather pathology and mutational biomarkers. And we also collect evaluations, CT scans, PET scans, MRI, just to see how the prognosis of the patient develops over time. Our data contains 475 specific data fields, all related to the clinical, diagnosis of GIST and the progression of GIST. We do have an in-house quality control. So every data that we not only collect, we also ensure that it's curated, because it later will be used for research, for collaboration, for partnerships. So we want to ensure that everything that's collected, it's always curated. It's important to know that our data follows all HIPAA compliant. We have an IRB approved study, which is the natural history for GIST. So all the data collected follows those patterns of HIPAA. So our aim, so why are we doing what we do? We want to understand the natural history of GIST. We follow clinical and treatment outcomes over time, and we would like to accelerate research with our real-world evidence. We also connect patients to the specialists. I feel like every time we get a newly diagnosed patient, or just any patient that gets to talk to us, the first thing we do is like, have you seen a GIST specialist? And I feel like that's very common, and think that we're able to have a great data set that it took a lot of work, and Laura was definitely behind that on creating that great list to have GIST specialists and connected to patients. And importantly, the registry is to help patients and caregiver navigate this journey. GIST can be very overwhelming, and we are always willing to help through the whole process, help patients understand different things, of course, connecting them with oncologists. We have a medical advisory board that we always run to whenever we have a question in regards to the collection of data or any concern that a patient may have. So, just a little timeline of how the registry started. Everything started with our executive director. He's very curious, and his wife happened to be diagnosed with GIST. So he started to collect data about GIST with a very small group of patients. He started collecting index cards in his kitchen table, kind of seeing patterns of GIST, and in regards to the clinical trial for Gleevec back in the day. So then he started seeing that the importance of collecting these, given the rare of GIST, there was a mission behind it. We really needed to help patients. And as you can see, the development of GIST started from index cards to now a SQL database. We're able to securely input data, extract data, and collaborate, and really expand into research. So as of today, we have over 2,000 patients, and it's very global. We have patients from countries that I never even knew existed, and I love doing that. I love really talking to patients that are outside our community and helping them in whatever form we can. And we also have a tissue bank, which is very important, and I will talk more about it in upcoming slides. But the great thing about our tissue bank is that not only we collect the data about GIST, but we also have tissue to support any future collaborations or analysis, which I feel with the development and research in GIST, we're going towards more genomic testing, biomarker testing, and tissue available. It's great to move forward that goal. So this is just a picture of, unfortunately, we haven't really had, due to the pandemic, the opportunity to do this, but I feel like I always represent registry and especially the LifeRef group. Our core is patients. You can see our smiles there. We're also happy to be among doctors, among patients, and just among us. It was just great to see them and really share the goal of the patient is the core of this. This is what it really drives us to do what we do. So just a little explanation of how the process of registry is. So patients submit an application, becomes part of the LifeRef group, and then they are willing to become part of the registry. And we collect all pathology reports, all mutational testing reports if they have had, any medical updates, any recent scans, biopsies, results for all that goes into registry. And then we also collect medications, dosages, side effects. We now have a platform of side effects that dedicates on not only the reporting of side effects, but the management of side effects. We collect things in regards to what the patient has done or what the doctor has prescribed for the side effect. And we're able to share that with other patients. So for example, for edema or for rashes, we're able to kind of like hydrocortisone or like the developments that a patient had, we share it. And of course, everything has to be shared with their oncologist first, but we like to be able to collect and manage the side effect. And after that process, we then set up a follow-up with the patient. Usually it's every time the patient had a follow-up or any type of scans or any type of change on their medication, we then follow up with the patient just to ensure that everything is well. And if they have any questions, we're always reminding them that we're here to help. So what's the benefit of being part of the registry as a patient? They have access to data in case they want to see. We always get calls like, Denise, like I'm a Kid Exon 9 patient. Have you seen any other patient like me? Like I want to have any type of guidance of a patient that's been through what I have done, like possibly like same tumor location or say tumor size or maybe same risk. So we're able to match patients and really provide that data, or of course with approval of any other patient that will to be connected. So they're able to get that data. They have insight into patients' outcomes. So we're able to share that what we have collected over years to what it reflects that they would like to know. Most importantly, they get to be connected to a GIST specialist. They're able to show their quality of life, side effect tracking and management, as I was explaining before. That's something that we're really taking a part of. We really want to make sure that the patient not only reports side effects, but we're able to help them manage them. Also, we have to have the help guide risk assessment. So with the information provided, we have a tool already built in Registry to share with their doctors. And in some cases, the pathology report already like shows the risk. So we just tend to explain that to patients or whoever needs them. And then we have a mutational testing service, which I will get into details shortly, but we're providing free mutational testing, advanced testing, next generation sequencing to all patients residing in the US that did not have a mutational testing, and it will be at free cost. And last but not least, we provide advice and guidance with patterns observed in data and results from researchers. So if we have anything published or anything that we have read in big journals like cancer journals or any type of big presentations like ASCO, ESMO, we're able to share that and explain to the patient, because I feel it's important for them to also gather that knowledge. So now one thing that we do in Registry, since we understand and know everything can be collected at once and it will be very saturated to have that for patients, we have the ability to do surveys. And this is great for collaborations with any other researcher or any other partnership, because it helps us understand traits that maybe we're not collecting in Registry and we're starting to see. For example, one of our quickest surveys that we have, and it was a great turnaround, was understanding why mutational testing wasn't done in our community. Another survey we had was, who's your oncologist? And that really helped us understand like who's been treated by who, and like really target like states that don't have that many doctors, or like patients are there and like they don't have access to a doctor. We were able to connect those patterns and provide additional list of doctors to our list. We have a new survey coming up, which is in regards to clinical trial medications, the behavior of patients, how do they feel, the experience of patients. So we're able to really implement and increase our knowledge on different aspects of GIST via survey. And we have a great community. I'm always so thankful for how our patient registry members are always willing to participate in surveys, and they're always happy to collaborate and be part of that. So another thing we do now, this is more like into the research of GIST, we're able to do case studies. So we really are able to, with the data that we collect, not only collect it, but also report case studies. We have published a couple case studies This is just a study that I found fascinating, and this just highlights the importance of really advanced testing. This patient was a 35 female patient. She was diagnosed at the age of 32. She was pregnant. And at the moment she was pregnant, she was going to her regular checkups, and they found a little fibroid on her ovary. So they're like, it's nothing. You're fine. Your baby's good. Keep it going. Like, everything is good. But now the baby, they kept saying, like, the baby is bigger than it's expected, but it's all good. He's a healthy baby. But it happened that on her C-section, the baby wasn't as big as they expected. And in fact, the tumor, there was a GIST tumor on her ovaries. So, high mitotic rate, stainings, all portrayed to be GIST. Patient had mutational testing. And of course, waiting for the results, she was placed on Imatinib, and she was responding. But then once the mutational testing came back, it says she was wild type. So then they stopped treatment, given that it wouldn't work. But now, since it was wild type, and then she joined the LIFERF group, and I said, like, it's important to have more additional testing just to really evaluate what type of mutation you have. Let's not just stop with wild type. So then they redid the testing, and in fact, she wasn't wild type. She was KIT exon 11, but it was in a section that it was really hard to target. And that's why the first mutational testing, the more basic mutational testing, didn't really see that portion of the KIT exon 11. Then she resumed Imatinib, and her tumor was drastically shrunk. Like, it was amazing. Like, her tumor was 15 centimeters, if I'm not mistaken. So it was a very large mass. And then now it was almost dissolved, which it was a great outcome. So things like that we're able to share. We're actually working on a paper just to show similar cases like this. So now I just have a little summary of the treatments that we have in Registry, the approved treatments. And I also like to always, when I'm talking to patients, I like to always share, like, the FDA label approval, the common side effects observed, the dosage, and how the milligrams and the capsules, because in some cases when we collect the data, the patients really don't know, like, oh, how many milligrams. So we're able to really target by the amount of pills they take. And you're like, that doesn't sound familiar. Like, I know my milligrams, but trust me, we have spoken to patients, especially, like, we'd have to talk to the wife, and the wife tells us, no, he's taking 400. He's not taking, like, whatever he's telling you. So it's always good to, like, have that visual of the amount of tablets and milligrams, so we can fully understand what dosage the patient is on. So one thing that I just wanted briefly to touch on, it's the different mutations we have and the importance of mutational testing. I'm not going to get to timing into details, but this is just a little breakdown of different mutations. And the most common one, of course, being KIT mutations in GIST, KIT exon 11 being the most common among all. Again, just like the frequency of mutations, KIT exon 11 of all the KITs exons, 11, it's the most common, being 67.5%. For PTGFRA, which is only 70% presented, the most common one is exon 18. And as we know, for exon 18, we do have an approved medication, Imatinib or Avakid, to treat that subtype of patients. These are great. Another great chart that we always share with patients is, it was published by Dr. Trent, and he shows the sensitivity of mutations among treatments, and resistant mutations. So it's great to really have that portrait of available treatments for GIST. Like, I feel like sometimes patients think like all the treatments work for all, or like, I feel like we're moving toward a more precision medicine world where we're able to really match patients to mutations and the mutations to treatments. So just a little summary of the previous thing. I'm just gonna quickly just go through this. So KIT exon 11, we know Imatinib, KIT exon 9, 800 for only advanced patients. Then we have PTGFRA DA42B, Avapritinib, we have FDA deficiency. Many more clinical trials are coming out for this subgroup, and Last, we have NTRK fusion. This is a recent, very rare fusion in just barely. We really have very, very few patients that have presented this fusion in our registry, but there is an available treatment for this category. Again, just wanted to emphasize about our initiative. We do have a free advanced mutational testing in the registry that we're offering at the LifeRF group. We partner with Bayer, and we are able to provide patients that haven't received mutational testing a whole panel of testing, and as well as patients that have had only basic mutational testing and had a wild type result. If they had that wild type result, we're able to advance it to really find their precise mutation. So if anyone has any questions about this or wants to be part of this, please, I'll be happy to guide and answer any questions, and we can start the process. Now that we have learned about the registry and data, let's talk about our research efforts. So what do we do with these registries? So we were able to, in 2018, we created an algorithm to change kind of like the behavior of SCH tumors. So we were able to change a guideline just to express the importance of testing for SCHB for all stomach tumors. So they were able to adapt the NCCN guidelines with the algorithm that we provided and with the data produced by the LifeRF group. These are some of our publications. We're really targeting collaborations. As you can see, we're trying to really highlight all the important things that we do just to really share with the community that what we do is, of course, help the patient, but we want to help the patient in every need that we can possibly can. And publications and spreading the word, awareness, education, it's one of our missions as a LifeRF group. So what's the next step? We really want to increase mutational testing rate for patients. We want to understand more about treatment response and advanced therapies, SCHB, IC under immunohistochemistry for all stomach tumors. We want to understand cell characteristics and behaviors of GIST. We want to have the global availability of treatments and tests. Our data, we do have a lot of data from the US, of course. Actually, it's the majority of our data, but we do have 30% of data that it's international. And our data from the US has really helped other countries kind of like push laws, help access to other medications. Like some countries don't have access to Sutent. Some countries don't have access to Regorafenib, which is something that's available in the US, and patients have shown a great amount of benefit from them. So we're able to share that, and then other countries were able to use that information to push laws and to get approvals for those medications. So we want to continue to support global efforts, and we wanted to continue to publish data, increase awareness, and of course, partnerships and collaborations is key as always. And thank you. I want to thank everyone for your time. And if you have any questions, please don't hesitate to email me.